Hi everyone, and in this video I'll be discussing another exciting topic, that is corticosteroids. We know that corticosteroids means two important things, that is mineralocorticoid and glucocorticoid. The main mineralocorticoid is nothing but the aldosterone, which causes sodium and water retention, which is required to maintain the blood pressure. The glucocorticoid mainly is cortisol, and that is required to maintain the stress. So whenever there is stress, this is also called as a stress hormone. And the adrenaline, the angiotensin 2, if they want to work efficiently, we require steroids. So that is called permissive action. So without steroid, person cannot survive. So it's a stress hormone. So let us understand this corticosteroid, taking certain cases and then understanding pharmacology. So there are three patients here. Number one, what drug is given along with adrenaline anaphylaxis? We'll understand that. Second, a pregnant lady is in preterm delivery. What drug are used for fetal lung maturity? Number three, a 32-year-old person on a drug for arthritis develops moon-like face, buffalo hump, high blood pressure, and increased glucose. What is the drug may be responsible for this moon-like face, buffalo hump, high BP, and high glucose? Let us answer these questions in the end of the video, and let us start our topic, corticosteroids now. So corticosteroids. So a bit of physiology first. Now we know that there is the adrenal gland. Adrenal gland, we have the cortex and medulla. From the cortex, the mineralocorticoid is released. So mineralocorticoid and the glucocorticoid and the sex steroids are released from this. And the medulla, adrenal medulla, will secrete the catecholamines, that is adrenaline, and one more is noradrenaline. So what we are going to deal now is the concept regarding the mineralocorticoid and glucocorticoid, and let us understand that. So first of all, let me take the concept of mineralocorticoid. So mineralocorticoid. So what is the mineralocorticoid mainly present in our circulation? It is called aldosterone. Now when we think of aldosterone, what does it do? It causes sodium and water retention. So it is known to produce sodium and water retention. What happens? Obviously the BP rises. So when the sodium and water retention occurs in the body, edema occurs. And the drug is also known to decrease potassium. So the aldosterone is known to decrease potassium. So that is the role of aldosterone. But one more role of aldosterone we studied in CVS. Aldosterone is known to produce ventricular remodeling. So it is known to produce ventricular remodeling. What happens if there is ventricular remodeling? It is mainly a problem in chronic CHF. So it increases mortality in chronic CHF patients. And that's why we suppress the activity of aldosterone in chronic CHF patients. So that is about the other concept. But here we are discussing the aldosterone and its uses. Can you use aldosterone in treatment? Remember, most of the endogenous substances what are there, you cannot use them because they are very short acting. So we have to prepare which are similar to that, and that's why we have drugs. So let us understand. So we will start with the preparations of mineralocorticoid. What are the preparations of mineralocorticoid? Let us see. The preparations of mineralocorticoid is something called DOCA. What is DOCA stands for? DOCA is desoxycorticosterone acetate. So that is DOCA. Then apart from that, we have a drug by the name fludrocortisone. It is called as fludrocortisone. And the endogenous one, that is called aldosterone. Aldosterone. Now these have the mineralocorticoid property, that is sodium and water retention property, as well as glucocorticoid activity. Now this DOCA has this one has zero glucocorticoid property, and 100 mineralocorticoid property. The highest mineralocorticoid property is present with aldosterone, that is 3000, and it has 0.3 glucocorticoid property. Now this fludrocortisone has 10 glucocorticoid property, 150 mineralocorticoid property, that is fludrocortisone. So they can ask in the exam which mineralocorticoid has zero glucocorticoid activity, that is DOCA. You can remember DO, O for zero activity. And others drug have some glucocorticoid activity, but zero is seen with DOCA. Can we use aldosterone in therapy? No, because it's very short acting. So what we use in therapy is by the name fludrocortisone. So let us understand where to use this mineralocorticoid fludrocortisone. The name is fludrocortisone. Fludrocortisone is used in a condition that is Addison's disease. Now, what is Addison disease? It's a condition where there is chronic adrenal insufficiency. That means adrenal gland is not producing the glucocorticoid and mineralocorticoid. So we use fludrocortisone. Why? Because it has both mineralocorticoid as well as glucocorticoid property. So what we do is, along with hydrocortisone, we add the fludrocortisone in the management of Addison's disease. Second important use of the drug is in managing hypertension. So fludrocortisone is used in the management of hypotension because you know that these mineralocorticoids increase the BP. Right? So we understood the concept of mineralocorticoids. So the next one what we are going to discuss is glucocorticoids. So what we are going to discuss in glucocorticoids is we'll understand the physiology, what is normal. Now, when we know the normal, that is actions of these glucocorticoids, we'll understand what is the use of that action and what is the adverse effect because of that. Is there any contraindication? We'll discuss that in a single concept. So we'll go with the conceptual manner and we will understand this. So what is the effect of glucocorticoids? Number one, in CNS. In the CNS, glucocorticoids are known to increase the mood. So they can increase the mood, and they are also shown to cause behavior changes. So behavior changes in the person. So which patient we should not give if it causes behavior changes? Obviously, steroids are contraindicated in patient with psychosis. So psychotic patient, steroids are not used. Second, it decreases seizure threshold. They are known to decrease seizure threshold. So which patients you should not give them? It is contraindicated in patient with epilepsy. So they are not used in a patient with epilepsy because they decrease the seizure threshold. But there is a condition called cerebral edema. Cerebral edema, we need to reduce the inflammation. Now these steroids are anti-inflammatory. The reason why edema occurs is because of TB or because of tumor. These are used, and the steroid of choice in managing that is dexamethasone. The steroid of choice is dexamethasone, which is used in managing cerebral edema. So in CNS, it increases mood and behavior changes. So don't give it in psychotic patient. It decreases seizure threshold, contraindicated. But a patient with cerebral edema due to inflammation, we use a steroid called dexamethasone. Now moving on to the next system, the CVS. What does it do in CVS? CVS is very important. It causes sodium and water retention. So steroids can cause sodium and water retention. What happens if they retain sodium and water? Obviously, the BP will increase, the edema will increase. Sir, will the glucocorticoid also cause sodium and water retention? Will the glucocorticoids also cause sodium and water retention? Yes, because some of the glucocorticoids also possess mineralocorticoid property, which I will explain later. So they can increase the BP and edema. So which patient it is contraindicated? Obviously, it is contraindicated in patient with hypertension and CHF patients. Correct? Now, another important aspect, I told you why these are most important for survival, because they have permissive action. So they have permissive action on two important vasoconstrictors, that is adrenaline, and one more vasoconstrictor, that is angiotensin 2. So that's what I told you. Whenever you are managing a patient with shock, why we also add steroid, because in the absence of steroids, these will not have full effect, that is the permissive action. So that's the reason why we add steroids along with other drugs to manage shock. Okay, so not only anaphylactic shock, septic shock, so then we are using steroids to increase the permissive action on adrenaline and angiotensin 2. Yes, so that is about the CVS concept. Moving on to the respiratory pharma, that is RS. What do they do? In RS, they are known to decrease the inflammation, and they are known to decrease the prostaglandin production. They are known to decrease the histamine production. They are known to decrease the leukotriene production. And we have discussed that extensively in bronchial asthma. So that's the reason it is used in the management of bronchial asthma. So steroids are used in the management of bronchial asthma because they suppress the inflammation, they decrease prostaglandins, histamine, and leukotrienes. Another important aspect of steroids are they are known to increase beta 2 responsiveness. Now, what is the advantage if they increase beta 2 response? They are particularly useful in status asthmaticus. So when the patient is on status asthmaticus, we know that steroids take long time to work. They are not going to work immediately, but the advantage is you have to dilate the bronchus, and if they increase beta 2 response, the bronchodilation will be faster. So that's the reason why these are used in attack of asthma, that is status asthmaticus. So that's why in status asthmaticus, what is preferred is IV hydrocortisone. So that is preferred here. Now moving on to another important aspect in RS, it is known to increase the pulmonary surfactant. It is known to increase pulmonary surfactant. So what is the advantage of that? The advantage is, suppose there is a preterm delivery. When there is preterm delivery, the baby is not grown or it is not matured, the lungs are not matured, the surfactants are less. If the baby is delivered like that, the baby will go for respiratory distress. So if I give steroids before the delivery, the lungs will mature, surfactant will increase, and the baby born will not have respiratory distress. That's why we do it in preterm delivery. So we give it in preterm delivery cases. So this is one more patient what we have discussed already. We discussed that patient already. That means a pregnant woman has preterm delivery. Why do you use that? So to increase pulmonary surfactants. So we're done with RS, we are done with the CVS, and we are done with the CNS. The next important aspect, what will they do with the immunity? What will they do with immunity? Particularly in bone marrow, do they have any effect? Immune cells. Now please understand, these steroids, they decrease T cells more than B cells. So which immunity is mainly suppressed by them? It is the cell-mediated immunity which is suppressed more than the humoral immunity. So they are known to suppress the T cells more than B cells. So since they suppress the T cells, these are also called as immunosuppressant. So steroids are immunosuppressant drugs. Now where do you want to suppress the immunity? Two important places where you want to suppress the immunity: when you are doing organ transplant. So problem is, when you transplant somebody's organ, our immunity will not accept that. It will try to reject it. So that time you have to suppress. Second, if you are dealing with an autoimmune disorder. Now what is autoimmune disorder? It's a condition where our own immunity is targeting our own cells. Example is rheumatoid arthritis, So here we have autoimmune diseases. So we have to suppress immunity there. But what is the disadvantage of suppressing the immunity? The disadvantage or the adverse effect is the patient is prone for opportunistic infection. Opportunistic infections. I think most of you have seen the pandemic where we used steroid and patient had fungal infection as opportunistic infection, that is mucormycosis. So this is the advantage of immunosuppression. Remember, not only organ transplant, autoimmune disorder, even we use it in the rejection, that is graft versus host disease also. Another important advantage of suppressing T cells and B cells is you can use it to treat leukemia. Steroids are used in treatment of leukemia as well as lymphoma. So why? Because leukemia and lymphoma, the T cells and B cells are increased, particularly the T cells, and we can suppress it. So which is the cancer where you should not use steroids? They are contraindicated in a cancer called Kaposi sarcoma. Kaposi sarcoma. Why? Because Kaposi sarcoma is a cancer seen in HIV patients. In HIV patients, already there is immunosuppression. If you use steroid, the immunosuppression will worsen and the cancer will also increase. So don't give it in a cancer called Kaposi sarcoma. So basically, steroids are immunosuppressants. Along with that, what about the other cells? What about the other cells? You told T cell, B cells, correct, sir. What about the other cells? They are known to increase the neutrophils. So they are known to increase neutrophils, good only. They are known to increase RBC. So we took the advantage of that and we can use it in autoimmune hemolytic anemia. Now they are also known to increase thrombocytes. Yes. Now these are the three things which are increased. But what do they decrease? Apart from that, they decrease the monocytes. They decrease the monocytes. They decrease the eosinophils. And they are known to decrease the basophils. So that's the reason they can be used in the treatment of allergic conditions. Steroids are used in allergic condition. A syndrome called Loeffler syndrome also it is used. And also another is bronchial asthma. It is used in bronchial asthma because in asthma patient the eosinophil activity is also high. So it can suppress that. So we are done with the bone marrow, and then importantly, these steroids have anti-inflammatory properties. So let us understand what is the anti-inflammatory property. So steroids are anti-inflammatory drugs. Inflammatory action of steroids. Okay. There is one more anti-inflammatory drug. They are called non-steroidal anti-inflammatory drugs. They are nothing but your diclofenac, aspirin, all those things. These are steroidal. Now, what do they do? What do they do? They decrease the interleukins, interleukin 1, interleukin 2, interleukin 6. Not only that, they are known to decrease the intracellular adhesion molecule. They are also known to decrease the ELAM, endothelial leukocyte adhesion molecule. And apart from that, they are known to produce annexin 1. Now, what does annexin 1 do? It inhibits the enzyme phospholipase A2. It inhibits the enzyme phospholipase A2. Sir, what is the role of it? Let me explain that here. Now, we know that membrane phospholipid, MP stands for membrane phospholipid, is converted into AA, arachidonic acid, with the help of phospholipase A2. This arachidonic acid is acted upon by two enzymes, the COX and LOX. So COX stands for cyclooxygenase, LOX lipoxygenase. So it will lead to prostaglandins, which are inflammatory mediators. Leukotrienes, again, they are also inflammatory mediators. So if you want to suppress this, there is production of annexin 1 by steroids, and that will inhibit the phospholipase C2. So because of these importance, they have shown to have anti-inflammatory property and also shown to inhibit the chemotaxis of neutrophils. So that is the advantage. So basically these are anti-inflammatory drugs. So because they are anti-inflammatory, where do you use them? So let me tell you the uses of anti-inflammatory. We can use it in rheumatoid arthritis, we can use it in gout, right? So we suppress this thing, and we also used it in COVID-19. What happened in COVID-19? There is something called cytokine storm. So that is a inflammatory process, and that was suppressed by steroids. And steroids are the only drug which decreased mortality in COVID-19. Steroids. So they are used in inflammatory conditions. But what is the adverse effect when you stop the inflammatory process? The adverse effect what we see is patient will have poor wound healing. So on steroid therapy, patient will have poor wound healing. Now please understand, whenever you get a cut on the skin, there should be inflammatory process to heal it back. Now when you suppress that inflammatory process, the healing takes longer time. That is called poor wound healing. So one is the advantage, one is the disadvantage with anti-inflammatory property. So moving on to the next important aspect, what do they do with skeletal muscles? Skeletal muscles, they are known to produce myopathy. The reason why do they produce myopathy is they increase the protein breakdown in the muscles. So they increase the protein breakdown in the muscles. What about in bone? In the bone, they are known to produce osteoporosis. Now, what is the reason why they produce osteoporosis? They decrease calcium absorption and they increase calcium elimination. So we know that calcium is vital for bone formation. So what we call it as steroid-induced osteoporosis. So if the patient is on long-term steroid, he will have osteoporosis. How do you manage this? What is the drug of choice for steroid-induced osteoporosis? Steroid-induced osteoporosis. They are called as bisphosphonates. They are called as bisphosphonates. They end with dronates. Okay, so moving on to the most important thing. What is the effect of steroids in metabolism? Very, very important. What do they do with metabolism? What does steroid do in metabolism? Now let me take the example of glucose. Now the name itself is telling you they are glucocorticoids. Obviously, they increase the glucose level. So if they increase the glucose level, which patient you should not use it? Obviously, they are contraindicated in a patient with diabetes. Second, protein. So they can cause breakdown of protein, that is negative nitrogen balance, and because of that, patient will have adverse effect, that is myopathy. Patient will have myopathy as well as skin atrophy. Skin atrophy. Number three, fat. Now what do they do with adipose tissue? They cause lipolysis in periphery. They cause lipolysis and periphery and deposit in the center. So when the steroids are given for a long period, they will cause lipolysis in the periphery. They deposit the fat in the center, that is the face, moon-like face, buffalo arm, and central obesity. So that is what we mean by Cushing's habitus. So patient will have the Cushing habitus here. Number 4, what do they do with calcium? I have discussed already. They decrease calcium absorption and increase calcium elimination, and that will lead to osteoporosis. So that is about calcium. And what about hormones? What do they do? Now, particularly thyroid hormone, T4 will become T3. Now, this conversion is blocked by steroids, particularly a drug called hydrocortisone. Now, this is what we take the advantage and we use it in treating a condition called thyroid storm. So, hydrocortisone is used in thyroid storm. So, basically, we understood the pathophysiology and where we use it and where we are not using it, that is contraindication, and what is the adverse effect. So we go in a systemic manner: CNS, CVS, RS. Then we discussed what happens in the immunity, what happens in anti-inflammatory property. Then we discussed the metabolism in brief, right? So simply remember, steroids increase glucose, they break down protein, they decrease calcium and cause osteoporosis, they break down fat in the periphery, deposit in the center, they have anti-inflammatory property, they have immunosuppressant property, and respiratory, asthma and preterm delivery, they are useful. They have permissive action on noradrenaline and angiotensin 2, so they are used in shock conditions. And in CNS, they decrease seizure threshold, not used in epilepsy condition. They can cause behavior changes, so they are contraindicated in patient with psychosis. So after understanding the concept about steroids, let us understand what are the preparation of steroids, what we use in the treatment of the patients. Now, these are the preparation of steroids. You can see here, we have classified the steroid depending on duration of action. The shorter acting steroid with a half-life of less than 12 hours, intermediate acting 12 to 36 hours, and longer acting more than 36 hours. So we have a drug by the name hydrocortisone, also called as cortisol. Then cortisone, we have prednisolone and prednisone. Remember, prednisone after metabolism will give rise to prednisolone, and prednisolone is the prodrug. So prednisone is the prodrug. After metabolism, it will give rise to the active compound, that is prednisolone. For prednisolone, if I add methyl, it becomes methyl prednisolone. We have triamcinolone, deflozacart, and two famous drugs, betamethasone and dexamethasone. I'll repeat again. If you know hydrocortisone, remove hydro, you get cortisone. If you know prednisolone, you have prednisone, which is a prodrug. Again, you will get prednisolone. Then for prednisolone, add methyl, it becomes methyl prednisolone. Then beta and dexa you already know. So what are the two drugs you have to remember? Triamcinolone and deflozacart. Now you can see here, we also mentioned it, they have some glucocorticoid activity and mineralocorticoid activity. Glucocorticoid activity is the one which we discussed now. Mineralocorticoid activity means they cause sodium and water retention. They can cause sodium and water retention. Now, you can see there is number 1.8445532425. Sir, what is this? Now, this is the potency of them. Now, hydrocortisone is 1 and dexamethasone is 25. What do you mean by that, sir? Suppose if I am using 20 milligram of hydrocortisone, what is the equivalent dose of prednisolone? If you get that, you have to divide this 20 by the 4. So the equivalent will be 5 milligram of this. Now, who is more potent? Can you tell me? Is hydrocortisone more potent or prednisolone more potent from this example? So lower the dose, more potent. So obviously prednisolone is more potent and less potent is 20 milligrams. So this 1 denotes potency. Now if I want to convert that into methyl prednisolone, divide that 20 divided by 5. So it will be 4 milligram. Suppose you want to convert in dexamethasone, divide the 20 by 25, you will get 0.8 milligram. So whatever the number they have given, divide it by that. So who is the most potent? You can see 0.8 milligram, lowest dose, the most potent, that is 25 times potent, is dexa and beta. Okay, sir. That is for dose conversion. Now what is that mineralocorticoid activity? 1, 0.8, 0.8, 0.8, 0.8, and last 4 drugs, that is beta, dexa, triamcinolone, they don't have mineralocorticoid property. Sir, why should I know this? Take an example. Suppose a patient has cerebral edema. Patient has come with cerebral edema. I told you we use steroids in cerebral edema. The option is, will you use hydrocortisone or will you use dexamethasone? A clinical question. You pause the video and tell me, will you use hydrocortisone or dexamethasone? Yes, you will be using dexamethasone. Now, why don't you choose hydrocortisone? The reason is hydrocortisone has mineralocortical property, that is one, and it will increase sodium and water retention and worsen the edema. Another application I will ask you, suppose a patient comes with Addison's disease or Addison's crisis, whatever. Again, I will ask you, will you give hydrocortisone or dexamethasone? What do you use? Pause the video and try to analyze. Now, you will choosing hydrocortisone in the management of Addison's disease. The reason is simple. Because hydrocortisone has both glucocorticoid and mineralocortical property 1:1. Dexamethasone doesn't have the mineralocortical property at all. What is Addison's disease? Is a condition where steroids are not produced from the adrenal gland. What are the steroids? The mineralocorticoid, glucocorticoid are not released. Then what is the treatment? Give hydrocortisone because it has both the properties. That is the reason. And that's why this table is important. One is dose conversion and choosing the therapy. And I told you the clinical application of both. So here we are in a position to understand the steroid, the pathophysiology, uses, the contraindications. So what I have done is, all this what concept we understood, we have made again a table for this. Let us understand what are the adverse effect of steroids here. So you have summarized that in one more slide. So the mnemonic for that is have good clips. Now you pause the video and try to look at the slide and try to analyze why this adverse effect occurs, because I have told you the concept already. So H stands for hyperglycemia. So steroids, glucocorticoids, the name itself is glucose, they increase glucose. Hypertension because they cause sodium and water retention. G for glaucoma on topical use. Please see that glaucoma on topical use means when you use eye drops as steroid, glaucoma increases. So there is a simple mnemonic. The mnemonic is GTCS. Now G stands for the glaucoma. So the glaucoma increases when you use the steroid topically. C stands for cataract. Now when does cataract occur? When you use steroid systemic. So remember the mnemonic GTCS. So growth retardation if used in pregnancy. So if you are using steroids in pregnancy, there is chance of growth retardations. For suppose a pregnant woman has autoimmune disorder and you want to use steroid for a very long period, then what to do? The best steroid in pregnancy will be prednisolone. So long term, if you want to give it in pregnant women, the best one is prednisolone. The reason is prednisolone will not be able to enter cross the placenta. It will not be able to cross the placenta. If it doesn't cross the placenta, then where is the question of growth retardation in the baby, that is fetus. Now why it is not able to cross? Because it is metabolized by the enzymes in placenta. So in pregnancy, if you use it for a very long period, then the preferred one is prednisolone. I'll ask you one more question, a conceptual question. Suppose we want to use steroid in a preterm delivery. We want to use a steroid in preterm delivery. You know that why do we use preterm? To increase the lung maturity by increasing pulmonary surfactant. Can you use prednisolone? No. Because prednisolone doesn't cross the placenta and it will not go to the fetus and increase the lung maturity. That's why prednisolone, methylprednisolone, they are not used in preterm delivery to increase lung maturity. So what we use is dexa and beta, which can cross it. So we'll discuss that again, don't worry. Moving on to the next concept, osteoporosis. We know why it causes edema, sodium and water retention. Osteonecrosis, that is avascular necrosis of mainly femoral head, has been shown when we are using steroid. Okay, so osteonecrosis of femoral head. Suppose a patient is already diabetic, the diabetes may get precipitated. That is what happened in pandemic. Most of them were COVID positive and diabetics. So we had to use steroid and suddenly the glucose level shot up. So diabetes got precipitated in them. So D for diabetes precipitation, C for Cushing syndrome. So excessive steroid from giving outside can cause Cushing syndrome, that is same thing. moon-like face, buffalo hump, then central obesity, all those things. And cataract, I told you on systemic cues, that is the mnemonic GTCS. Yes. Limb muscle atrophy. Why muscle atrophy? Because protein breakdown is done by steroids. Lipolysis in periphery and redistribution, and that is what we mean by Cushing habitus. Impair healing of wound because of the anti-inflammatory property. Why peptic ulcer? Can you guess why peptic ulcer? Now in GIT, who guards the stomach? The stomach is guarded by prostaglandins. And I told you steroids decrease prostaglandins. What happens if you decrease prostaglandins? Patient will have gastritis, and gastritis will lead to peptic ulcer disease. So that's the reason they can cause peptic ulcer, gastritis. Now patient may be susceptible to infection because they are immunosuppressant. There is a concept called suppression of HPA axis. I will explain that. And seizures, I told you, they decrease the seizure threshold, and skin atrophy because of protein breakdown. So the mnemonic is have good clips, you know already, but we made a mnemonic and giving again to you to understand this concept. So H, hyperglycemia, hypertension, glaucoma, growth retardation. If you are using in pregnant, where growth retardation? In the fetus. Osteoporosis, edema, osteonecrosis, diabetes precipitation, Cushing syndrome, cataract on systemic use, limb muscle atrophy, impaired healing of wound, peptic ulcer, susceptible to infection, suppression of HPA axis, seizures, and skin atrophy. Now, the question here is, what is HPA axis suppression? Now, HPA stands for hypothalamus, pituitary, adrenal axis. So it is called hypothalamus, pituitary, adrenal axis. So hypothalamus secretes cortisol releasing hormone. It acts on pituitary, and pituitary releases ACTH. And when ACTH acts, adrenal release the corticosteroids. So we know this. Now whenever the steroids, that is steroids are excess, steroids can control this axis. They inhibit the axis. So it's a negative feedback mechanism. We all learned when the steroids go up, when the steroids level go up, they tell the hypothalamus to keep quiet, pituitary to keep quiet, then the secretion of steroids decreases. Now when you are giving steroid from outside, steroids like drugs are given from external. Suppose we are giving the drug to the patient, what happens? These steroids will inhibit this HPA axis. They will inhibit the HPA axis. So what happens? If you are giving steroids every day you are giving steroids, what happens? This HPA axis will sleep. Suppose one day you stop the steroid, this HPA axis will not work and they are not able to produce the steroids. If the steroids are not released, you know that steroids are for emergency and stress. So patient may have the HPA axis suppression, patient may go for low BP, the cardiac vascular abnormalities, and he may slip to coma also. So that is the reason when you are using steroid, this HPA axis should be made active. Now how to make active? If you are giving steroid and inhibiting them always, they will not be active. Then when does this occurs? HPA axis suppression occurs not if you use steroid for 1 or 2 days. 1 or 2 days you and stop, nothing will happen. If you are using steroid for example hydrocortisone 20 to 25 milligram or the equivalent of this. I have told you the equivalent of this prednisolone 5 milligram, methylprednisolone 4 milligram. If you are using it for minimum of 2 to 3 weeks, so when you are using for this many duration, there is a chance of this. Now why the chance? Because when you are using for a very long period, the HPA axis will sleep, and when suddenly the steroids are stopped, these will not work and they will not give a command for adrenal gland to secrete steroids. So how to avoid this? That's the best question they will ask you in the exam, how to avoid HPA axis suppression. So consider that you are giving some money to a person So until unless you are giving the money to that, he will not work because somebody is giving money. So what you have to do, you have to do that intermittently. Same thing, if steroids are coming from outside, the H and P will not work. And suddenly the steroids are cut down, they will forget their work. So the point what you need to do is you have to do this intermittently. So try to give the steroid alternative day. Okay. Second, wherever possible, the problem is seen when you are giving systemic steroid. Wherever possible, try to give local more than systemic steroid. For example, a patient is having asthma. Don't try to give oral drug. When we give inhalation, they work only in the lung, so the problem will not occur. So patient can take years together, nothing will happen. But if you give orally and suddenly stop, HP axis suppression. Another important aspect is whenever you start steroid, give low dose steroid. Low dose steroid is started. Low dose steroid. So will you give a short acting steroid or long acting steroid? Think and tell me. Will you prefer to give short acting or long acting? Yes. Short acting should be preferred more than long acting. Because if steroids are longer acting, the HP axis will be suppressed. If they are short acting, after their action is over, again HP axis will work. That's the reason. Another important point is, if I want to give steroid to a person, should I divide the dose or should I give the dose at one point of the time? So don't divide the dose. Give dose in early morning itself. And don't divide it. So don't divide into early morning, afternoon and night. Because when you divide that, the steroids are longer acting and the HP axis suppression occurs from morning, afternoon, and the night. So if you give in the morning, at least in the night, when the steroid levels are low, they can get up, they can start working. So point to observe, alternative day, local is preferred, low dose of steroids are started, short acting is best. Don't divide the doses. Try to give it in the morning or afternoon and don't give it all the 3 times. Most important is when you stop the steroids, if you use steroids for a very long period, don't stop them abruptly. So gradually taper the dose. And then stop. So this is what we did in pandemic also, because steroids were the main therapy, decreased mortality. So for example, 60 milligram for 3 days, then 30 milligram for 3 days, again 15 milligram, 10 milligram, like that. So gradually the dose has to be tapered and stopped. So this is a very important question in your exam, how to avoid HP axis suppression when you are using steroid. Please understand, steroids are beautiful drug if you use them properly. But when you use them for a very long period, you will see the adverse effect of them. So until now, we understood the glucocorticoids, the preparations, and what is the pathophysiology, where to use them, what is the adverse effect and contraindication. So what we are doing right now is we are summarizing them at one slide. So in the next slide, what I am going to discuss is the contraindications. So let them be at one slide. Let us discuss the contraindication. So when I write the contraindication, you should be thinking the reason in your mind. So first of all, let me write the contraindication: epilepsy. Now why? They decrease seizure threshold. Psychosis. Why? They cause behavior changes. Then they are contraindicated in a patient with CHF because they cause sodium and water retention. They are contraindicated patient with hypertension, edema. So in all these patients, it is known to increase sodium and water retention. Then what about infections? It is not used in viral and fungal infections. Viral and fungal infections, it is not used. The reason is it's an immunosuppressant, so viral and fungal infections may flare up. You may ask a question, sir, we used in COVID-19. What we did in COVID-19 is first 1 week, we gave an antiviral drug. The next week we started steroids. So the problem was cytokine storm, and we want to suppress the immunity at that time. So we had to use steroids in certain situation, but usually we avoid them in viral and fungal infections. Now it is also avoided in something called TB. Which TB is it avoided? Ileocecal TB. Ileocecal TB. Why only in this case? Because it has shown to increase the risk of perforation. So perforation risk has been increased in ileocecal TB. So that is about the infections. What about the other important things we need to understand? Peptic ulcer. Why? The reason is they decrease the protective gastroprotective prostaglandins. Then renal failure. The reason is again sodium and water retention, and steroids are eliminated by kidneys also, so that will increase the steroid levels. So this is the reason in renal failure. Then they are not used in a patient with osteoporosis. Now you know that steroids themselves can cause osteoporosis and they can increase risk. So again, telling you, epilepsy, psychosis, CHF, hypertension, edema, viral and fungal infection, TB, peptic ulcer, renal failure, osteoporosis. And tell me, what is the cancer where we should not use? It is called Kaposi sarcoma. And can we use it in a patient with glaucoma? No, because topical use of steroids, they themselves increase glaucoma. So these are the other contraindications of steroids. Okay, so once we understood the contraindications, again let us summarize the uses of steroids. Uses of glucocorticoids. So I can categorize the uses like this. Number one, diagnostic. So where do you use diagnostically? What do you want to diagnose? We use it in a test called dexamethasone suppression test. So the test is called dexamethasone suppression test. And where do you use this test? This is used to check the integrity of HP axis. So whether it is functioning or not, you will understand with that. And also to diagnose Cushing syndrome. So the test is called dexamethasone suppression test. That is the diagnostic. Second important use is the replacement use. Replacement. Now when I discussed general pharma, I told you the drugs are used as replacement. Now where do you replace steroid? There are two conditions where you have to replace steroid. What are those? The acute adrenal insufficiency, also called as Addisonian crisis. Addisonian crisis, it's an emergency, so we have to use a drug, and that is called IV hydrocortisone. IV hydrocortisone. What about the chronic adrenal insufficiency? It is called Addison's disease. So it's a chronic condition. So here also what we use is, along with hydrocortisone, we add one more drug that is called fludrocortisone. So that is the replacement use. The third important one is in the pregnancy. So the third important is in pregnancy. I just told you in pregnancy we use it in a condition that is preterm delivery. Preterm delivery. And one more is congenital adrenal hyperplasia. So in a pregnant woman we use it in preterm delivery as well as congenital adrenal hyperplasia. Okay, so continuing with the uses of steroid, I told you they are used diagnostically. Second, they are used in the replacement. And third, they are used in pregnancy. Now, what is the pregnancy condition I told you? The pregnancy condition, what we are going to use is preterm delivery. In pregnancy, we use it in preterm delivery. Now, why are we using in preterm delivery? I told you they increase the lung surfactant production. Not only that, they also have shown to decrease the respiratory distress, and they also have shown to decrease the risk of patent ductus arteriosus, which can develop after the birth. Not only that, they have also shown to decrease necrotizing enterocolitis in the newborn. These are the advantages what the steroids have. But remember, basically, when you use it in preterm delivery, it is known to increase the lung surfactant. And that is an advantage, so that when the baby is born, has adequate surfactant, so there is no respiratory distress. Now, what are the two steroids which are commonly used for this? One is betamethasone. The name is betamethasone, and the dose of betamethasone is 12 milligram. And how do we give it? We give it by intramuscular. And should we repeat it? Yes, you have to repeat this. Again 12 milligram with a gap of 24 hours. So the doses are 2 and the gap is 24 hours. Another drug is dexamethasone. The name is dexamethasone. It is also given IM. But here, how do we give it? 6 milligram. Again we give 6 milligram. Again we give 6 milligram. Again we give 6 milligram. So here the gap between the doses are 12 hour, 12 hour, 12 hour. So totally dexamethasone are given as 4 doses. And the total duration to complete is 36 hours. Betamethasone takes 24 hours to complete this. So which one looks better? Betamethasone. Now in our country, betamethasone ampoules are not easily available. They are available in some places. What is easily available is dexamethasone. That's why it is preferred. Otherwise, if betamethasone is available, that is also preferred. So betamethasone, the advantage is only 2 doses and the gap is 24 hours. Dexa you have to give 4 doses, and to complete that you take 36 hours. So simple. In the alphabet, the letter B is second, so 2 doses. Dexa, D, the 4th letter, 4 doses. After we understood that pregnancy, we use steroid in preterm delivery. One more pregnancy condition where we use it is a condition called congenital adrenal hyperplasia. So there is a condition called congenital adrenal hyperplasia. So what is the problem here? The problem here is the enzymes required for steroid synthesis are deficient. Example, the most common is 21 hydroxylase deficiency. Now when this is not there, you know that cholesterol will give rise to all these steroids, and that will not be able to perform steroids. The hypothalamus, pituitary, adrenal axis, we all know. Hypothalamus will tell pituitary to release the ACTH. ACTH will tell the adrenal gland to release the corticosteroids. Now corticosteroid synthesis is inhibited because the enzyme is deficient. What happens? The hypothalamus pituitary keeps on more and more pressure on adrenal gland, so they will stimulate it more and more. So adrenal hyperplasia occurs. Now when the baby is born with this problem, it doesn't have steroids. So when the baby is born, the BP is low, the sodium is low, but the potassium is high. Not only that, when you block this enzyme 21 hydroxylase, the cholesterol biosynthesis will move towards more and more testosterone synthesis. Congenital adrenal hyperplasia will also have virilization features, and that will lead to the ambiguous genitalia, particularly in the female, ambiguous genitalia in the female fetus. So when the baby is born with this problem, what is the treatment they can ask you? The treatment is hydrocortisone. Now why hydrocortisone? Because it has the mineralocorticoid as well as glucocorticoid activity, and it can correct the BP, it can increase the sodium and decrease the potassium. because you know that when the hormones are not synthesized, aldosterone is not there, glucocorticoids are not there, so BP falls, sodium falls, potassium rises. So the drug of importance and the drug used for this baby is hydrocortisone. So what about virilization? That has to be corrected surgically, and that will be dealt by surgeons. Now another important is, let us consider that this woman has given to birth to the baby with congenital adrenal hyperplasia. Now she becomes again pregnant, and there is always a risk she carries for the second baby also. Suppose the second baby we also suspect it may be born with this problem, then what we do is we have to take precaution. So she is pregnant now. So if she is planning for pregnancy, what we need to do is we have to start dexamethasone. So dexamethasone, if she is confirmed in pregnancy, we have to start at 6th week or as soon as pregnancy is diagnosed. So as soon as pregnancy diagnosed, the dexamethasone has to be started. Now, then you determine the sex. If it is male, then you have to stop the dexamethasone. If it is female, you have to continue till delivery. Okay, so if it is male, you have to stop it, and if it is female, you have to continue till delivery. You may ask a question, sir, what is the use of giving dexamethasone? When we are giving dexamethasone, what happens? We are providing steroids. That means congenital adrenal hyperplasia will not occur, and the cholesterol will not be diverted towards the synthesis of androgens. So the virilization will not happen. So there is decrease in virilization of female fetus. So that's the reason why we have to continue giving dexamethasone till the birth. Once the baby is born, again you have to give hydrocortisone. So, but in a male, there is no problem of virilization, you can stop it. So, a pregnant woman already has given birth to a baby with CAH. Second pregnancy also has a risk. So, what we do is we start dexamethasone at 6th week or as soon as pregnancy is diagnosed. But should we continue? Male, stop it because there is no risk of virilization. But in a female, there is a risk of virilization. We have to continue till delivery. So, this is the question. Please read the question carefully. What you give to the baby is hydrocortisone. Baby born with that hydrocortisone. What you give to a pregnant woman is dexamethasone. This is very, very important. So until now, I discussed with you all what are the uses of steroids, diagnostic, then replacement, then pregnancy. What are the other therapeutic uses? What are the other therapeutic uses of steroids? So let me summarize them. So because it has anti-inflammatory property, we use it in rheumatoid arthritis, we use it in the patient with gout, we use it in psoriasis, and also it decreases allergy. So we use it in patients of allergy, we use it in a patient with asthma. They suppress the immunity, so we use it in organ transplant. We use it in organ rejection, that is graft versus host disease, and also we use it in leukemia, lymphoma conditions. Okay, so we have discussed all these things. Apart from that, is there any other use of steroids? Special uses, they are also used in chemotherapy induced nausea vomiting, CANV. The drug that is preferred is dexamethasone in CANV. Again, it is used in cerebral edema. So cerebral edema, the preferred one is again DEXA. Now, there is a condition called Duchenne muscular dystrophy, and the drug which is approved for that is, the name of the drug is deflazacort. So it has shown to be beneficial in these patients, that is Duchenne muscular dystrophy. So one use of the steroid I told you is Duchenne muscular dystrophy. It is deflazacort. They are also used in TB meningitis. Sir, now you told TB we should not use it. Now I told you should not use it in ileocecal TB, which can cause perforation. TB meningitis, if I don't suppress the inflammation, patient may end up with seizures. So I have to use it for a brief period and then stop it. Then one more condition is neurocysticercosis. Neurocysticercosis, we know that we use anti-helminthic drug and the drug of choice is albendazole. But when you are using albendazole, what happens? The larvae are released and they cause inflammation. Again, patient will have seizures. So to avoid inflammation there also, we use steroids here. The other condition is COVID-19, and I told you COVID-19, it decreases mortality. It decreases mortality, and one more important is lepra reaction. So lepra reaction are two types, both type 1 and type 2 lepra reaction. It is the drug of choice are steroids. So this is the extensive use of steroids which we already know, but I'm just summarizing that in a one slide so it is easy when you revise it again, guys. Okay. So until now we know the uses, adverse effect, contraindication and the concept of steroids. The last one is the management of Cushing disease. So they can ask you what are the drugs used in Cushing's disease. What is Cushing disease? The problem is in the pituitary. So pituitary secretes more on ACTH and more ACTH will stimulate the gland, adrenal gland to release more steroids. So in managing Cushing disease, we have three strategies. What are the three strategies here? Number one, to inhibit steroid synthesis. So to inhibit steroid synthesis. So what are the drugs which inhibit steroid synthesis? They are called aminoglutamide. So we use an antifungal drug. It is called ketoconazole. Any anesthetic which inhibits steroid synthesis, it is called etomidate. And we have something called metyrapone, then something called metotane. The special of metotane, it has adrenolytic property. Adrenolytic also called as cytolytic property. So it can cause the cell lysis. So it is used something called medical adrenalectomy. It is used in medical adrenalectomy. So many a times the tumors of adrenal gland cannot be removed by surgery. Surgery is not possible. Then we have to give the drugs and suppress the adrenal gland. So the name is metotane, which has cytolytic or adrenalytic property. So it is used for medical adrenalectomy. Now, apart from that, we have something called trilostane. And a new drug, it is called osilodrostat. So the name is osilodrostat. It is known to inhibit 11-beta hydroxylase. So it's an enzyme required for steroid synthesis and that is inhibited by osilodrostat. You may ask a question, sir, where do you use these things? Usually in Cushing's disease, where the operation is not successful or not possible, then we use them. What is the second strategy? We have the somatostatin analog. So what is the name of the somatostatin analog used? The name is called pasireotide. So pasireotide has shown to decrease the effect of ACTH. Another important is a drug which is used in obstetrics. What is the name of that? It is the glucocorticoid receptor antagonist. Not only that, it is also progesterone receptor antagonist. Take a guess. The name is called mifepristone. So mifepristone is also being tried in Cushing disease. So Cushing disease, there is excess of steroid synthesis in our body because of the pituitary cause, and then we stop the steroid synthesis, or we use somatostatin analog, or we use glucocorticoid receptor antagonist, that is mifepristone. These are the therapies. Okay, so we started our journey of corticosteroid from these cases. What drug is given along with adrenaline anaphylaxis? So along with adrenaline, we add steroids because steroids have permissive action on this adrenaline. Not only this anaphylaxis, other shocks also we use steroid because they have permissive action on adrenaline and angiotensin too. A pregnant ladies in preterm delivery, what drugs are used for fetal lung maturity? The dexa and betamethasone, beta 2 doses, dexa 4 doses. Why they increase pulmonary surfactant? 32-year-old person on a drug for arthritis develops moon-like face, buffalo, high BP, increased glucose, which a drug may be responsible. They are steroids. Now, I told you if you are using steroid for brief period, they are very good drug. But if you are using them for very long period, patient will have the adverse effect like the Cushing habitus, high BP, high glucose, peptic ulcer, and osteoporosis. All these are the long-term complication with steroids. So summarizing the corticosteroids, I told you there are two important mineralocorticoid, glucocorticoid. Mineralocorticoid main drug is fludrocortisone used in hypertension as well as Addison's disease. Glucocorticoids, I told you the concept, what happens in CNS, CVS, RS. They are anti-inflammatory drugs, they are immunosuppressant drugs, and they increase glucose, they break down protein, they break down fat in the periphery, deposit in the center, they cause osteoporosis, and after that I told you what are the adverse effect. So if you know the concept, adverse effect is easy. If you know the concept, contraindications are easy. And then I told you the uses, the number one, diagnostic use, then the replacement use, number three, the pregnancy use, that is preterm delivery and congenital adrenal hyperplasia. Then other uses also we discussed. Most importantly, you should know how to avoid HPA axis suppression, and we discussed that points. And lastly, what are the drugs used to manage Cushing disease? So that is about the corticosteroid preparations and corticosteroid topic. Thank you all.